Good evening, everyone. Dr. Feynman. Tonight, we're going to be talking about central blood pressure, central aortic blood pressure. It's a little bit different than what you normally get when you get your blood pressure checked in your arm. And so tonight, we're going to talk about a new toy that we got at Apollo Cardiology that actually checks the central blood pressure non-invasively. So I've previously done some videos on how to optimize your blood pressure. It's mostly about endothelial function, that inner lining of your arteries. It's 1 cell thick. It's like a gel coat to the inner lining of the arteries. And one of the things that it does is it releases nitric oxide. If you're low on nitric oxide, the smooth muscles in the arteries can't relax, and the flow pressures increase. So if you see me in the office, we're frequently talking about the elasticity of the arteries and nitric oxide. I've previously done talks about how to actually measure your blood pressure. So just a quick review. Ideally, you shouldn't have any stimulants in your system, so no caffeine, no alcohol within a few hours of getting your blood pressure checked. If you want an accurate blood pressure, you should be sitting down, resting for 5 minutes, feet on the ground, back supported in a chair, and your arm should be at heart level. You should ideally have a manual blood pressure cuff to check your blood pressure. At the office, we have a mercury tube, old school. That's still the gold standard to manually take a blood pressure, is using a column of mercury to measure the systolic, the top number, and the diastolic, the bottom number. So normally you're checking the brachial artery, that's right in your bicep area. You're measuring the blood pressure there. And that's a good estimate of what your blood pressure is, but it's not a perfect one. And when I was an invasive cardiologist, I frequently would do heart procedures where we put catheters or tubes in the arteries, either in the femoral artery down in their leg or the radial artery in the wrist. And we'd feed a catheter up into the heart, and we'd put contrast on the arteries to take pictures of the arteries. But we also would use a catheter called the pigtail catheter to measure pressure measurements inside the left ventricle, the main pumping chamber. And then we'd pull back on that pigtail catheter across the aortic valve, and we would leave it in the ascending aortic root, and we'd measure the pressures that were coming out of the heart. So we'd measure the aortic pressure invasively. So I did thousands of those in my career, and that's actually the blood pressure that your heart, your brain, your kidneys, and your organs actually sees. Blood pressure in the arm is a little bit of a inaccurate measurement sometimes. We really want to know what the blood pressure is at the heart level, because that's what the heart is sensing. The aorta just comes right out of the heart, and that's the pressure that really matters for stroke risk, heart attack risk. And I frequently talk about 300 or 400 different things that can drive atherosclerosis or plaque in the arteries, but high blood pressure is high on that list. That's the classic, even conventional cardiovascular risk factors, high blood pressure. Now there's a whole quantum reason why. Again, it's the gel coat, it's the endothelial function, it's the glycocalyx, it's the lack of nitric oxide, and we'll talk about that in future videos. But let's talk about a little bit more about blood pressure itself. So, thank you for everybody who's joining. We're just going over the details of what central blood pressure is, or central aortic blood pressure is another term for it. So invasively, you can measure a pigtail catheter, but if you're coming into an outpatient office, you're not going to be willingly having a tube put into one of your arteries to measure this pressure. So there's a device called the ATCOR, ATCOR, multi-$1,000 device that I acquired for the practice to be able to measure this non-invasive central aortic blood pressure. So it has a brachial blood pressure cuff. So I want people to be rested, feet on the ground, back supported, arm at heart level, and then the machine takes a brachial blood pressure, so you get your systolic, the top number, you get the bottom number. But then it does a about 10-15 second measurement of the elasticity of the arteries, and then it will calculate the central aortic blood pressure. So the way you think about a central aortic blood pressure being monitored is that when the blood leaves your heart, the blood leaves the heart, goes into the aorta, and the aorta, if it's healthy, should act like an accordion. It should expand quickly, contract quickly. So the blood gets pushed down to your brain, your arms, down to your legs. But you can think about it as if you've ever been in a pool and you splash the water at the wall, and then that water comes back at you. Well, as the blood leaves your heart, goes down the aorta, and goes down to the smaller blood vessels, as the resistance in those blood vessels increases, basically the tubes are getting smaller, or there's a branch point, the blood hits that point and reflects back to the heart. And so the heart is squeezing the blood out, but the reflection wave is coming back. That can augment the pressure. And that augmentation of the pressure is what the heart is actually seeing. So your central aortic blood pressure will be measured with that reflection wave. If you have really stiff arteries, you have calcifications in the arteries, you have scar tissue in the arteries, typically more common as people age. You're gonna have like lead pipe arteries, and the blood's gonna leave your heart, go really quick through that artery because it doesn't expand and contract. When the accordion type of the aorta expands, it's dissipating energy outward, and so that kind of slows the blood flow as it's going down, slightly slows it down. But if you have a concrete pipe, the blood just like bounces back and boom, it just rebounds very quickly, and that pushes that augmentation pressure much higher. So your brachial pressures, the pressures in your arms, typically are going to be higher than the pressures in your central aorta. And that's the key, is that sometimes one of two things happens. Is you measure the blood pressure in their arm, and let's just say, for example, it's 160/90. That's going to be a high blood pressure in your periphery. But that central aortic blood pressure, let's say it's 110/80. That's normal. That's what your heart, your brain, your kidneys is sensing. And since that's the organs you actually care about, you almost like don't care so much that the pressure's high in the arm. Maybe there's a stenosis in your subclavian artery. Maybe the arteries in the arm is really stiff. Okay, you still need to address that, but you shouldn't be hammering them with more and more blood pressure medications, because then you're going to decrease the perfusion to their heart, their brain. Maybe they're going to get dizzy, lightheaded, maybe they're going to start passing out. So if your arm pressure is much higher than the central pressure, you treat the central pressure. Now, if they're both pretty similar, okay, you're still treating the central pressure ideally. And so, 120/80 is really the goal for your central aortic blood pressure. The other real interesting thing is that different blood pressure medications, if you end up on them, have different effects. Some of the blood pressure medications will affect the brachial blood pressure, but it really has no effect on your aortic blood pressure. So you're going to see these lowering blood pressures in your arm, but the pressures coming towards your heart stay the same or are higher than what you would really expect. And so you'd have to adjust your medications to things that actually affect the central pressures. The things that tend to affect the central pressures more are the ACE inhibitor class of medications, the angiotensin receptor blocker, the ARBs, and the calcium channel blockers. The diuretics, like hydrochlorothiazide, the beta blockers, like metoprolol, they can lower the blood pressure in the brachial artery, but they don't really have an effect on the central pressure. So that's why most trials that compare meds head-to-head, they don't tend to do as well in those trials. So not saying to stop those medicines if you're on them, but you need to talk to your doctor if you're on them to make sure that your central pressures are actually optimized. And then this test also, other than just giving you the central pressure, will give you something called the Augmentation Index. It's just a metric essentially of that elasticity of the artery, how springy is the artery. I also have a piece of equipment in the office called the Max Pulse that also gives you that information, so you can kind of correlate, do they actually match up. So that's what I want to share with you guys tonight. The central blood pressure, it's the actually most accurate blood pressure to be monitored. It's the number one thing that, predicts the risk for heart attack, stroke, kidney failure. So you need to know what your blood pressure is. The best surrogate that most people have is going to be a brachial blood pressure. It's good, but it may not be enough. So if you have access to a central blood pressure machine, go get it done. If you're in St. Louis and you're my patient, you're going to be having it done every time you come and see me in the office. So that's what I'm going to share with you guys tonight. And let's see, I have somebody asking a question here. So somebody's asking, can I comment on the symptoms of swollen, painful feet in terms of a heart condition? Without examining it, it would be hard to know exactly what's driving it, but you can kind of think of that, is it something that is pretty much constant, 24/7 it's present, or is it that's present during the day, and then when you've, elevated your feet at night, the swelling pain goes down? That gives you a little bit of differential. Is it, more of a venous issue or an arterial issue? Sometimes when the feet are chronically swollen and they don't get better, sometimes that's a pump issue. The patient has either diastolic or systolic heart failure. Other things that can drive swelling in the feet is if you have kidney dysfunction and you're leaking protein in the urine, you'll have swelling in a lot of the periphery. If you have liver failure, which would be uncommon, it could be a cause of swelling in the feet. If you have a vasculitis or an inflammation of the arteries to the legs, you can have swelling, painful extremities. So there's multiple things on the differential. Most doctors, if they examine it, would be able to tell, what is your capillary refill? Are your feet cool? Is it hot? Is there something else going on with a rash? So, but yeah, definitely chronically swollen feet that are painful need to be checked out. There's definitely biomarkers that you need to check. You can check high sensitivity CRP. If you're concerned about a vasculitis, you can check, a SED rate, an ANA, an ANCA, an ANCA, and see if it's likely that somebody has a vasculitis. But it's one of those things that have somebody go lay eyes on it and actually examine it, and they should be able to kind of point you in the right direction. All right, and so thank you everybody for joining. Is there anybody that has any questions about central aortic blood pressure or just blood pressures in general? If there's no question, that's cool. Next week, I guess I'll be probably getting a Clearly scan to look at the health of my coronary arteries. It's a invasive, mildly procedure. It requires an IV and IV contrast to take very detailed 3D pictures of the coronary arteries, the three arteries that's on the outside of the heart. Not expecting to get a bad report, but it's something that looks at the soft plaque, if there's any necrotic plaque, the stuff that tends to cause heart attacks, or any calcified plaques. I've had previous CT coronary calcium scores that have been 0, so I'm not expecting to have significant calcifications in my coronary arteries. But this test is kind of cutting edge. They use AI and machine learning to take a very detailed look at the coronary arteries, and it'll tell people almost like virtual histology what's going on in the arteries. So, it doesn't really, interest me that people have plaque in their arteries. It interests me in that, is that plaque going to rupture and cause that person an event, a heart attack or stroke? And this test is Clearly health scan is going to help me kind of help differentiate that for the people who are more intermediate or high risk. So I'll probably be giving that test next Monday. If everything goes well, I'll share some information that night about it. And then the results generally can take a couple of days to come back, and then probably the following week I'll go through my results if everything looks good. But I know I do owe some people a heart rate variability talk. We'll get that done in the next couple of weeks. Heart rate variability is one of the best metrics of how recovered you are from exercise, but it's also a very good metric of just general cardiovascular well-being. It's also a pretty good marker if you're becoming sick with some type of viral illness. So if you have good heart rate variability and also falls off a cliff, be concerned that you're coming down with something. So thank you all for joining tonight. Have a great week. Have a Merry Christmas if you celebrate that, and we'll see you next Monday.